So good morning, everyone. On this busy Sunday morning, I welcome you all on the behalf of CVCCON-Alpha series. And this CVCCON-Alpha series is designed for introduction of any new technology, new modality into the medical field. And today we are going to discuss such a very interesting modality for the treatment of osteoarthritis of knee joint, and that is a genicular artery embolization. So root of cause, this is very important word in anybody's life. And root of cause, this word is more famous and more popular into the engineering field rather than the medical field. But if we find root of cause of any problem, then success is very handy. So today we are going to discuss the root of cause for osteoarthritis of knee joint. Traditionally, what we believe that wear and tear phenomena, it leads to the osteoarthritis of knee joint, but it's true. But along with this wear and tear, is another cause is a chronic inflammation. Continuously, this inflammation process going on within this knee joint, and it leads to further cartilage damage, and along with that, the neoangiogenesis occurs. So what is the neoangiogenesis? Neoangiogenesis is a hypervascularity developed into this due to this chronic inflammation, and this chronic inflammation leads to the new formation of these microvessels, and these newly formed microvessels continuously releasing the cytokines within this joint, and because of these cytokines, continuous destruction of this joint going on. So now what is a chronic inflammation basically? So chronic inflammation is a culprit in many diseases like macular degeneration. Macular degeneration is also a very common disease, and basically there's a continuously inflammation process going on within the retina, and in this retina is these newly formed these microvessels continuously leads to inflammation and damaging to the retina, and it leads to hampering the vision. And the macular degeneration treatment is also depends on preventing this chronic inflammation. So they obstruct these newly formed microvessels. Not only macular degeneration, Alzheimer's disease, also even these arthromatous changes into the blood vessels, these all diseases are witnesses of chronic inflammation. And in this COVID-19 pandemic era, all this, there is no antiviral medicine for COVID-19 virus, right? But all this treatment is planned and designed to prevent the inflammatory reaction of the body. So inflammatory reaction is also very important thing. Whether we use a steroid for as an anti-inflammatory, or another medicine like remdesivir, that is an immunosuppressant for COVID-19. But all these are basically preventing the inflammatory reaction and cytokine storms creating due to the inflammatory reaction, and it helps us to treat the COVID-19. Similarly, for genicular artery embolization, it is also going to help us to prevent the chronic inflammation into this knee joint, and further damaging the underlying the knee joint. So let's understand first how this genicular artery embolization helpful for osteoarthritis of knee joint. So basic concept of osteoarthritis of knee joint, basically there is a cartilage which is give the cushioning effect between these two bones, and this cartilage gradually erodes and it reduces the joint space, and because of this reduction of the joint space, friction between these two bones occur, and it leads to the pain. Now pain is a very dominant complaint for any patients. It starts with the morning stiffness, but gradually this pain leads to pain occurs when the movement of the joint, and pain reduces into the resting positions. Along with this pain, if there's a swelling develop over the knee joint, this is due to the synovial effusion. Some hard swelling is due to the osteophytes, and many these grinding sensation also occurs while we are using this joint. These all due to the osteoarthritis of the knee joint. But in all the patient, dominant complaint is a pain, and because of the pain, there's a restricted mobility of the patient. And if the pain is relieved, then the patient's quality of life is improved significantly. There are many factors which are affecting this disease: aging, weight, definitely genders. Women are more affected than men, and some professional hazards for the marathon runner and athletes, which they are overusing the knee joint. It's very easy to diagnose osteoarthritis. Even the plain X-ray gives lots of information. By recognizing the joint space narrowing, we can diagnose that osteoarthritis process is going on. Even the staging also very accurately done on the plain X-ray. But USG and MRI also very important modality. By using the power Doppler, we can define the hypervascularity of the synovium. Similarly, in MRI, there are lots of other signs which shows there is a chronic inflammation process going on within the joint. So, for osteoarthritis of knee joint, these investigations are very important, and particularly when we are planning for genicular artery embolization, power Doppler and MRI are the very important tool to define severity of chronic inflammation within the joint. So there are total four stages of osteoarthritis. Grade 1 is a mild one, and grade 4 is a severe one. In a grade 4, there is no joint space, there is no cartilage left. So pain is maximum into a grade 4 stage. Now currently in osteoarthritis of knee joint, the treatment divides into the two parts. One is operative and second one is a non-operative. In non-operative segment, when the patient first complained of pain and morning stiffness into the joint, then we prescribe some medicines for painkiller and cartilage rejuvenation, and also prescribe some physiotherapy and weight loss. See, weight loss is very important. I'm going to describe you why it is more important. And another non-operative treatment is intra-articular injection of steroids or PRP. These injections are really helpful for temporary, but underlying, unless you treat the underlying, the etiology, underlying the root of cause, pain is going to recur. And what happened that all these non-operative treatment fails and only option is operation, that is a total joint replacement surgery. So till date, there is no other option is available between this non-operative and operative treatment. I mean, non-operative treatment, I give more weightage to this weight loss. What happened that if you reduce the weight of 1 kg, then it is going to reduce the 4-fold pressure into the knee joint. So by putting the effort of 1x, we are getting the result of 4x. So obesity and weight reduction is important, very, very important into the osteoarthritis of knee joint patient. So in this osteoarthritis of knee joint patients, when the patient starts complaining pain, we try all these non-operative treatment, giving the painkillers and some intra-articular injections of physiotherapy. But at one stage, all these non-operative treatment stops working. And then the only option for the patient till date, that is a replacement of the joint. That's a major surgery and you are going to lose your nasal joint. Till date, there is no other options available in between these non-operative and operative. But there's a young intervention radiologist, Dr. Yuji Okuno. He is from Japan and he has published his research first time in 2014. And he has given the hope that genicular artery embolization, it gives relief into pain and it stops the cartilage destruction within the joint. His first paper published in 2014 and later on many papers published, recently one paper published in 2020. All these different papers suggest you of the pain reduction after the genicular artery embolization is 86% at 86% in the first 6 months, and follow up after 3 years also 80% pain is reduced after the genicular artery embolization. So this procedure is very good, successful. So now, what is the reason how this genicular artery embolization works? So let's find out the root of cause. Traditionally, we are thinking that wear and tear is the only culprit for the osteoarthritis of knee joint. If we use more knee joint, then cartilage damage is going to happen. But this is true. But along with the wear and tear, there is a chronic inflammatory process is going on within the joint. Let's understand this vicious cycle. So what happened? That first cartilage damage occur, and because of the cartilage damage occur, this inflammatory process starts within the body. And when the inflammatory process starts, the body releases the cytokines. These cytokines are two types. One which is helping to rebuilding the tissue, and another cytokines is just opposite to it, that is helping to destroying the tissue or the pathogens. In layman language, we can consider that these cytokines or this inflammatory reaction is just like our Indian Army. Indian Army fighting at the border with the enemies, and simultaneously it build the bridges over the river, it build the roads over the into the border area. So balance between these two is very important. Cytokines are two types, but the balance between the bad type and the good type, it's very important. Unfortunately, what happened into the chronic inflammation? Into the chronic inflammation, this neoangiogenesis occur. What is a neoangiogenesis? That is a newly formed microvessels. And these are very important process of chronic inflammation that this neoangiogenesis occur. It leads to the hypervascularity into the localized region. And because of this hypervascularity, continuously cytokines released into that region. And these cytokines going to damage further and further the cartilage. And so once this cartilage damage continues, it gives another signals for inflammatory response. So there is a vicious cycle going on continuously. And to prevent this cycle, we have to prevent this hypervascularity. So for that, if we embolize these newly formed microvessels, which is shown over here, see these are hypervascular, these are newly formed microvessels. These are main vessels, and here is this neoangiogenesis and the hypervascularity. If we target these vessels, if we embolize these vessels, then this vicious cycle stops. Chronic inflammation process stops within the joint, and it helps to prevent further damage to cartilage. And it is helpful for further process of helpful for stopping the further process of osteoarthritis. There are many studies which suggest of increased vascularity due to the chronic inflammation, and this process is going on continuously. So selective genicular artery embolization is very important to break the cycle, to prevent the cartilage damage, and it is helpful. So let's see the examples now. So in the first example, there is a patient over here. We can see there is a mild to moderate osteoarthritis. The joint space is still preserved, but patient has continuous pain since 3 years, and he has taken lots of non-operative treatment, but still patients complaining the pain. Now it's MRI done, and MRI shows here the synovial effusion near the medial condyle of the femur, and at the same side, when selective genicular angiography done, this shows the hypervascularity. So combination of the MRI, this is a sign of chronic inflammation, and it confirms on the selective angiography. These are highly combination and highly these are good indication for genicular artery embolization. If this hypervascularity is embolized by small particles, if this vascularity disappears, like in this case post-operatively, so here what we have done this in this case. That is we embolize these microvessels, the hypervascularity disappears, so chronic inflammatory process disappears, it stops over here, so further cartilage damage is stopped. Now in the same patient, there is a graph for the changes of pain score. At the day of embolization, pain reduces the 50% on the same day, and gradually over the period of next few months, the pain is completely disappear. So what is the reason of this sudden and sudden reduction of the pain? So this is very important etiology to understand. Because of this neoangiogenesis, along with these newly formed microvessels, there is a sensory nerves also develop. And when we target these microvessels, when we embolize it, when we obstruct these microvessels, along with these microvessels, these sensory nerves which develop with these microvessels, these also destroy. And these sensory nerves are the main culprit to send the pain signals from the joint to the pain. So patients relieved by this pain from the same day, at least 50%. So this is the beauty of the procedure. As I've told you that any osteoarthritis of knee joint patients, basically dominant complaint is of pain. If you relieve the pain from the patients, patient lives a very happy and healthy life with the same natural joint. So genicular artery embolization is a blessing for lots of patients. Now for embolization, Dr. Yuji Okuno suggestive of imipenem as an embolic material. See, there are two embolic materials. One is a temporary and second is a permanent. Dr. Rozil in the follow-up lecture is going to explain you into details. But Dr. Okuno is suggestive of imipenem, which is widely used as an antibiotic. But when these antibiotics mixed up with the contrast, it creates 10 to 17 micron particles. And these particles are ideal for blocking these microvessels. In side effect, there is no side effect observed while we are using this imipenem, temporary embolic material. But while we are using this permanent embolic agent, so there is a side effect while we are using the permanent embolic agent. And local skin necrosis or temporary peripheral numbness observed because of the non-target embolization. This is another example. While we are taking a shoot into the superficial femoral artery, these all genicular arterial branch appears, but it's very difficult to define the hypervascularity. So for that, we have to do the selective angiography. Like in here, there is a superolateral genicular arterial branch is selective angiography done, and with this angiography, we are able to find out this vascular flush over here. This is a triangular area shows hypervascularity. These are newly formed vessels over here, and patient has a pain in the same region, and MRI also shows this chronic inflammation into the same region. So this is an ideal case, and once you embolize these patients with this temporary embolic material, this hypervascularity disappears over here, like over this case, and chronic inflammation stops, and patient's pain also disappear, and patient's quality life also improve without any operation. This genicular artery embolization is very important procedure. It done under the local anesthesia. Patient has to stay for 1 day, from morning to evening, and it done with one needle puncture, no cut, no surgery, and you preserve your natural joint. So which are the indication for genicular artery embolization? Definitely, this should be done into chronic pain. The pain should be more than 3 months old, not responding to other non-operative treatment like physiotherapy and medicines. And spontaneous pain, including night pain and race pain, these are the very good indicator for finding out the abnormal new vessels at the origin. So if this complaint is present into the patient, then we can find out, we can say that there is a chronic inflammation process going on within the joint, and these are the ideal candidates for genicular artery embolization. Even the local tenderness over the joint, it also suggestive of this hypervascularity arising from the chronic inflammation. And pain occur during the climbing of the stairs. See, these very important tools, because when the pain occurs while walking on the flat surface, so that is a very advanced disease, grade 4 disease. But while pain occur only during the climbing of stairs, this suggestive of mild to moderate osteoarthritis, and for this genicular artery embolization is very good modality. Definitely young age group patients where the joint, their natural joint preservation is a main concern, genicular artery embolization is really helpful. And for the extremely old age group patient where the surgery itself is a very high risky, for this kind of patient also genicular artery embolization is very useful. And definitely patients who does not want to go for a joint replacement for surgery, for them this is a really blessing procedure. They got relieved by pain due to the osteoarthritis of knee joint with this procedure. So now let's see the contraindication of this procedure. Definitely acute pain is not treated by this procedure. Infection within the joint, rheumatic arthritis is not indication for this procedure. Acute traumatic pain is avoided, and severe arthrosis changes into the leg vessel, particularly superficial femoral artery, then this procedure should not be done into the patients. So many of my orthopedic colleague friends are asking me, will it replace to TKR? And I always tell them TKR is, this procedure is helpful for mild to moderate osteoarthritis. So TKR is not going to obsolete. But it's too early to say. Let's see how the future unfolds. But genicular artery embolization is very useful for many patients. And if you ask me what is a single important criteria for the patient selection, so genicular artery embolization is particularly meant for chronic inflammation. So we have to find out the chronic inflammatory process within the joint, and for that two important tools. One is a tenderness at the site, and in MRI there is a synovitis at the same site. See, these are the two important criteria. If these are present, I would recommend for genicular artery embolization. If we do the selective genicular artery angiography, definitely hypervascularity present in the same area, and if we go for embolization, then patient will improve symptomatically. So in conclusion, we have seen lots of literatures which are suggestive of more than 80% pain relief with this genicular artery embolization. So previously there was no option available between these non-operative and operative treatment, but with promising results of genicular artery embolization, it has given an option for and it has given a good alternative for operative treatment. And particularly genicular artery embolization, it treating the root cause of osteoarthritis of knee joint. So it is going to be very beneficial to all the patients. So thank you so much. And now I would like to hand over the mic to Dr. Rozil Gandhi. He is my colleague, and we have formed the team for this genicular artery embolization. He is a very dynamic young intervention radiologist, and he is particularly interested into the vascular intervention and particularly into embolization. So he is going to talk about how do I do it or genicular artery embolization. So how this procedure should be done. So Dr. Rozil, I'm handing over mic to you. And if you have any queries to audience, please send us your queries. We are going to answer all your questions. If the time doesn't permit, we are going to reply you back. You can call me or Rozil directly for your any queries also. Rosil. Huh? Okay, okay, okay. Sorry.
Yeah. Sorry for the glitch. Thank you, Dr. Mohal sir, for the introduction. Can you hear me, right? Hello. Dr. Mohal, can you hear me?
Yes, 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 you go ahead.
Okay. So I'll be talking about how to do genicular embolization, how I do it. Very nice introduction by Dr. Mohal. Basically, we are here to reduce the vascularity and thus reduce the inflammation which is causing pain. So we are here to reduce the pain and improve quality of life for the patient. What does an intervention radiology do? We do something for almost all the branches of medicine: vascular, oncology, nephrology, gastro, chest, and pain. So here we'll be talking about pain in osteoarthritis. How do we assess the patient? We assess the patient by clinical examination, check for the tender areas, ask history, what is the duration of pain, see how the patient is walking, take radiographs, AP and lateral, check for the scoring, severity of the osteoarthritis, get an MR study done before the embolization, and check for blood parameters. So check for the reflexes, see how the knees are swollen or not, whether there is movement abnormality or not, get an MRI done, get a radiograph done. Very important, WOMAC scoring for pain. It is an objective evaluation. How does the patient respond before and after embolization? How does the patient respond with medical management? Indications already mentioned by Dr. Mohal. Knee pain should be chronic, more than 3 months old. Medical management has failed. There is spontaneous rest pain, local tenderness, pain during climbing. Patient is in young age group or an extremely old age group where TKR is not indicated, where there is a complication. Patient who doesn't want joint replacement surgery. Patient with joint replacement surgery still having pain. What is the vascular anatomy of the knee joint? Predominantly, knee joint is supplied by the genicular branches of the femoral and the popliteal arteries. But there are also lateral circumflex femoral, circumflex fibular, and recurrent branches of anterior tibial. They form the anastomotic network. So the person who is doing this should be very well versed with the anatomy. Schematic figure A, it is the descending genicular artery. B is the superior medial. D is the superior lateral. Similarly, E is the inferior lateral. C is the inferior medial. And F is the recurrent genicular artery. These all branches of the femoral, distal femoral and the popliteal go into the joint, around the joint, supply the synovium. So depending on the part of the tenderness, we should embolize it. Prerequisites, as I already mentioned, evaluation by MRI, X-rays, and pre-op blood investigation to check for coagulation parameters. Generally, we use an antegrade femoral puncture, insert a 4 to 5 French femoral sheath, have a diagnostic catheter up to the distal femoral artery, use a microcatheter coaxially through the diagnostic catheter, and after super selectively cannulating, inject an embolizing agent, that is imipenem. Doing an angiogram, we evaluate the blood supply of the inflamed synovium and super selectively cannulate the branches. This is how the particulate matter go into the capillaries. This is the neovascularity, and it embolizes it. It closes off at capillary level. So the main trunk of the artery is always patent. Coming to the angiograms and cases, this is the common femoral artery angiogram, this is the superficial femoral, and this is the deep femoral. This is the distal femoral artery, this is the patient with TKR, this is the DSA image, subtracted image. You can see the black hypervascular blush more on the medial side. We are going super selectively into the medial artery, superior medial genicular artery. You can see the blush. This is pre-embolization. This is post-embolization. The main trunk of the artery is patent while the blush has gone. So the blush is embolized. Similarly, another images showing pre-embolization and post-embolization images. Descending genicular, you can see mild blush, and this is post-embolization. So what we do basically is we keep the major arteries patent, we keep the main trunk patent and embolize the blush. So that the synovium, there is just a temporary embolization to the synovium hypertrophy. So the neovasculary gets destroyed, and thus there is no more sensory nerve stimulation, and it helps in pain relief. Just to keep you all awake, this is the biopsy of the dorsal vertebra. Needle is typically in the lesion. Middle-aged female, multiple vertebral lesions. After removing the trocar of the needle, you can see high blood flow. So needle is not in the aorta but in the vertebral artery, but in the vertebral body, but this was a metastatic hemangiosarcoma. Okay, coming back to our genicular artery. Multiple episodes of hemarthrosis after TKR in a 66-year-old male, twice aspirated but recurred within a week. This is the clinical picture. You can see the right knee joint is swollen. This is the angiographic picture. This is the descending genicular. This is the superior medial genicular. This is the distal femoral subtracted angiographic image. You can see the abnormal blush here from the superior medial genicular. We have gone super selectively. This is again the same image showing better. The blush is seen better here. You can see the same image in the angiographic phase, but later the blush is seen better, and this is post-embolization. The rest of the arteries are patent. The main trunk proximal is patent, but the blush is gone. Videos. You can see the same image. This is the blush seen on the angiographic image. Super selective cannulation coming very near to the artery, and this is inside the artery. Typical blush, and this is how we insert a coil. We push the coil through the microcatheter. This is the microcatheter. It is through the diagnostic catheter. Coil is pushed here on the left side image. Into the artery. Another case, as I told you, we keep the main trunk patent but embolize the blush. The blush is seen in the black arrow. The right image doesn't show the blush, just the patent trunk of the main vessel. Advantages of this procedure: it is a day care procedure with less than 50 cc of non-ionic dye used. Done under local anesthesia, no risk of DVT, no risk of infection. Patient can be mobilized after 4 hours of the procedure. That is the major advantage. Complications: there can be non-target embolization, embolization to the other vessels other than the genicular arteries. There can be skin changes, numbness, but that all can be prevented by use of temporary embolic agent like imipenem, which we use. So there is minimal or almost no complication. There can be renal issues due to contrast, but we can pre-evaluate this patient with a creatinine and blood parameter level. It is safe, effective procedure. As a conclusion, it is under day care, local anesthesia. It will have an important place in between the medical management and TKR. This is because this is minimally invasive. To conclude, almost all studies give 80% pain relief at 3 years, which is very good. At the end, this is another example how intervention radiology helps. This is DJ stent in the pulmonary artery, which we are snaring. So this is one non-target embolization of right pulmonary artery by the DJ stent, which you have snared and removed, as you can see in the right-sided video. This is the snare that is trying to grasp. And now it has grasped and it is taken inside the sheath. Thank you for the patient hearing. This is an image of contrast media, ultrasound. This hypervascular tumor, and this is post-ablation. No contrast uptake, suggestive of complete ablation. Just few videos of intervention radiology to keep you entertained. And with this, I conclude my session. If there are any questions related to genicular artery embolization, its role, how do we do it, what is the place in the clinical management of patient, we are here to answer.
Hello.
Yes, Dr. Mohal.
So there are a few questions on our chat box. So let us answer one by one. The first question is how long this treatment will last once done, and is it need to do it again in any circumstances? So this is very good question. Basically, all the literature shows 3 to 4 years follow-up, and at the 3 years follow-up, 80% of the pain is relieved. So this treatment lasts for a long time. More than 3 years, there's a pain relief. That is very long duration of time. We don't have much data about more than 3 years, but definitely this procedure can be repeated at any time if repeat MRI shows there is a chronic inflammation is going on. And what is the second question is can we do it again in any circumstance? Yes, we can do it again at any time, because it's an embolization. If any new hypervascularity develop, we can embolize it anytime. Third question is, what is the side effect of this treatment? The side effect is already shown by Dr. Rozil, that we have to prevent the non-target embolization. So super selective genicular artery embolization is very important. We have to preserve the normal branch, just only targeting the newly formed microvessels, and that's why expertise come into the picture, because we have done we are more experienced for the any embolization, so we can handle this genicular artery embolization better. And one question from Vishal Makwana: how much total expense for this surgery? Rosil, do you want to answer a few questions?
Yes.
Yes.
Question of Mr. Vishal. In the basic category ward in a corporate hospital, this procedure will cost around 70,000. Another question is, can minor knee ligament tear be normal? No, we can't treat minor knee ligaments with this embolization. It is only for osteoarthritis, for synovial inflammation for osteoarthritis, not for traumatic ligament tears. What about sectorial avascular necrosis and increase in cartilage damage? The studies have shown this doesn't cause avascular necrosis because we are not embolizing the artery supplying the femur. What we do is we do temporary embolization of the neovascularity. The main trunk of the artery is still patent, so there is no necrosis. There is just embolization or stopping of neovascularity, and it helps in pain relief. Buttock claudication we can't treat. Buttock claudication can happen with iliac artery stenosis, vascular disease. For that we do vascular reconstruction, we do stenting or angioplasty. So we have to really evaluate what is the cause of buttock claudication, and that depends, and the treatment depends on the cause. What is the cost of the treatment that we have already told. Now another question by Vishal. Me and doctor, how many successful treatment completed till today? Me and Dr. Mohal might have done around 5 of these cases, but we do embolization of the entire body day in and day out. That must be in thousands. Worldwide, the total number of cases of embolization of osteoarthritis would be around 500 to 1,000 worldwide. But adding me and Dr. Mohal, we must have done more than 1,000 embolizations. I mean closing of the arteries of the entire body for different purposes. Dr. Mohal, you might want to add something.
Yes, definitely. Basically, all these questions are more towards their patients looks very anxious about the how this treatment unfolds and how the treatment is effective. But I personally feel this root of cause is chronic inflammation along with this wear and tear. And if we treat this, if we are able to stop chronic inflammation with the genicular artery embolization, selective genicular artery embolization, while preserving the normal genicular artery, and with offsetting these newly formed vessels, pain reduction is very significant. And one another question: can this procedure be done for patients with diabetes and cholesterol? Yes, absolutely. See, with the diabetes and cholesterol, we can do it. And actually, these are advantages for such kind of patient, because these are totally non-operative procedure. The procedure is done under the local anesthesia with simple needle puncture. So for diabetic patient, if these osteoarthritis induced pain, then it is going to be very beneficial. I think so. There's no more questions right now. If anybody has any questions, you can contact me or Rosil. You can contact us on directly mobile also, or send us into this comment box. We are going to reply back. thank you so much for giving your precious time on this Sunday morning to understand this new technology. And genicular artery embolization, I think so it is a big breakthrough for pain management for such kind of chronic disease. Even though Dr. Yuji Okuno has done lots of cases for frozen shoulder and many non-union fracture for us of the small bones also, and for tennis elbow also, and in all this case results are very promising and highly successful for relieving the pain. And here is the same: target the newly formed microvessels into the chronic inflammation and embolizing, and pain will be relieved. So thank you so much for
thank you
listening us.
Thank the viewers. Yes.
Thank you, viewers, and if you have any question, do contact us. Thank you so much.
Thank you.